I want to tell you about a patient I saw in clinic a couple of weeks ago. She came in holding a letter from radiology, her mammogram result. She's been on HRT for 2 years. Her flush is gone, sleep restored, felt like herself again for the first time since her mid-40s. Then she got her radiology report. It said her breast density is category C, heterogeneously dense, or mixed density. Somewhere between reading that letter and sitting in my consulting room, she had already decided she needed to stop her HRT. She hadn't spoken to her GP. She hasn't contacted me. She has just decided. Because the letter said dense breast. She knew that way we all kind of know from something we read once or someone has told us that dense breasts mean higher cancer risk. It must be that HRT caused the density. Therefore, she will develop breast cancer because of HRT. So, she needed to stop HRT. The reasoning isn't completely crazy. It is completely normal and understandable. But it is also not a full picture. I'm Dr. Alex Popovich, a breast surgeon and menopause specialist. I see women at the intersection of HRT and breast cancer every single week in my clinic. I'm making this video because I'm tired of watching women make fear-based decisions. So today, that is what we are going to do. Chapter 1, what breast density actually is. Let's start with the basics, because a lot of confusion begins here. A mammogram does not for lumps. It reports on composition of your breast tissue, specifically the ratio of glandular and fibrous breast tissue to fatty tissue. And we call this breast density. And it's relatively new. There are 4 categories. Category A is almost entirely fatty. The mammogram looks dark and reading it is relatively straightforward. Category D is extremely dense. The mammogram looks very white and it can be technically harder to detect abnormalities within all that white tissue. And most women fall somewhere in the middle, category B or C. Here is the important part. Breast density is not a pathology. It's not a disease. It's not a tumor. It's purely a description of the composition of your tissue. The same way someone might describe you as having thick hair or fine hair like mine. It is just a characteristic. Dense breast tissue does 2 things that are clinically relevant. First, it can make mammograms harder to read. Dense tissue and small early cancers can both appear white on a mammogram, which is why women with dense breasts may be recommended additional imaging. Second, high breast density is associated with increased lifetime risk of breast cancer. Chapter 2, breast cancer risk across density categories A to D. So now you know what the 4 density categories look like on a mammogram. What does each density category actually mean for breast cancer risk? Category A is almost entirely fatty breast. This is actually associated with the lowest breast cancer risk of all 4 groups. If anything, very fatty breast tissue carries a slightly below average risk. And the mammogram is easier to read, and these women do not carry additional density-related risk. Actually, they have lower density-related risk. Category B, scattered fibroglandular tissue. This is where most women fall, and the risk is broadly average. It is not a finding that should alarm you. The mammogram is still straightforward to interpret, and no additional imaging is typically required based on density alone. Category C, heterogeneously dense. This is the category my patient was in. The evidence suggests women with category C density have roughly 20% increase in breast cancer risk. Category D, extremely dense breast tissue. This carries approximately 2 times the risk of average density. The mammogram is also technically harder to interpret, which is why additional imaging such as contrast-enhanced mammogram or MRI, or very rarely ultrasound, is more commonly considered in this group, particularly when other risk factors are also present, like family history. Now, let's make this concrete, because numbers in isolation are almost meaningless. The lifetime risk of breast cancer for a woman in the general population is approximately 12%. And we sometimes say that 1 in 8 women will get breast cancer during their lifetime. This is the baseline we work from in New Zealand. And this is what the average risk means. If you're category A or B, your density is not adding meaningfully to that figure at all. Actually, category A, it reduces slightly the risk. So your lifetime risk from a density perspective remains in the range of the average, which is around 10 to 12.5%. In UK, as well as Australia, is slightly higher, 15%. If you're category C, that increases your risk by around 20%. So a woman starting from a baseline of 12.5% is looking at the lifetime risk in the region of 15%. Now, if you are category D density, that risk is around twice of the average risk. So if the baseline is 12.5%, now it comes closer to 20 to 25% over a lifetime. But this is not the same risk as a BRCA mutation carrier carries. That risk of, if you have one of those BRCA mutations, that risk may be between 60 and 90% depending on the type of mutation you carry. Now, I want to be honest about 2 things here. First, density-related risk does not exist in isolation. And since alongside your age, your family history, your weight, your alcohol use, and yes, your HRT, and also your diet. And all those factors interact to give you your breast cancer risk. Density is just one piece of the information, not the whole story. And second, this is something I say to my patients regularly. Knowing your density category is not the same as being told you have cancer. It's information that should prompt a conversation and possibly a recommendation of what type of imaging might be beneficial in your case. Chapter 3. What HRT actually does to your breast density. So now we know what breast density is. Does HRT change it? Yes, in some women, HRT, particularly combined estrogen and progestogen, can increase breast density. We know that from quite a few studies. It is quite a known effect of certain HRT formulations. But not all HRT is the same. The type of progestogen matters enormously. Synthetic progestogens, also called progestins, which are used in some older combined oral HRT preparations, have a greater tendency to increase breast density than the body-identical progesterone, also called micronised progesterone. In New Zealand, the only brand that we have is Utrogestin. So body-identical progesterone, when taken orally or vaginally, has a much lower association with breast density change and importantly, a better safety profile when it comes to breast cancer risk overall. This is why, in current evidence-based prescribing, many clinicians, including myself, prefer body-identical progesterone where appropriate. Now, does increased density on HRT mean increased breast cancer risk? And the honest answer is, it's complicated, and we don't know everything yet, so the evidence is still evolving. What we do know is, number one, HRT-induced density changes are often reversible when HRT is stopped. 2. The density increase does not appear to carry the same independent cancer risk as if you have naturally occurring dense breast tissue. And 3. The absolute risk increase from HRT remains small in absolute terms, even though it is real. But what is also true is that stopping HRT has costs, real costs. Your symptoms are back. You have accelerated bone density loss. You get sweats. And for many women, a significant deterioration in their quality of life. Chapter 4, the screening question. A question I often hear in my clinic: if I have dense breasts, whether naturally or from HRT, do I need extra screening? And does that mean a mammogram is not enough? In women with very high density, category D, or in women with other risk factors such as strong family history or personal family history of breast cancer or a known genetic mutation, additional imaging such as contrast-enhanced mammograms or MRI may be appropriate as an addition. But for most women on HRT, including the ones on category C density, which is the most common finding, the standard recommendation is not to stop HRT. Women with breast density C and D should definitely discuss their individualized breast cancer risk with their doctor or a breast specialist. Chapter 5. How to have this conversation with your doctor. I know that clinical appointments with doctors are short, and it can be quite hard to know what to ask. If you're on HRT and you receive a mammogram report commenting on breast density, here are the questions worth asking either your GP, your gynecologist, or a breast specialist. Question 1. What type of HRT am I on, and does it affect breast density? If you're on combined preparation with synthetic progestogen, density is a concern. So it may be worth discussing whether switching to body-identical progesterone is appropriate for you. This may not always be possible, and it may not always be the right choice. But it is a good question and conversation to have. Question 2. What category is my density, and what does it mean for my screening? Category B is common and generally requires no change, same as category A. Category C warrants conversation and personalization. Category D may warrant additional imaging depending on your overall risk profile. Question 3. What is my overall breast cancer risk? Density is one factor, but other factors include family history, personal history, weight, alcohol use, HRT use, as well as diet. And no single factor tells the full story. Ask for your risk to be considered in the context, and then your imaging should be applied to your risk. Question 4. What would stopping HRT cost me? This is a question women often do not think to ask because they're focused on density finding. But it is the other side of the equation. Hot flushes, sleep disruption, joint pain, mood changing, bone density loss are all real consequences of stopping HRT. And that cost needs to sit alongside the risk when you make the decision. Which one is a higher risk? Which one is a better? Question 5. What is the plan going forward? What is the monitoring interval? When is the next mammogram? Under what circumstances should you come back sooner? Leave with a clear plan, not just a conversation. You're allowed to ask all these questions. You're allowed to take notes. You're allowed to bring someone with you. And you're allowed to say, I need a moment before I decide anything. So what happened to the patient I told you about at the start? We sat together for about 25 minutes. I explained what category C density means. I looked at her specific HRT formulation. I went through her family history, her personal history, her overall risk profile. And then at the end of that conversation, the decision she made was to stay on her HRT. She was already on body identical progesterone, and she's going to continue with annual mammography rather than 2-yearly mammography. And it was a different decision to the one she made alone in her kitchen, because now she had the full picture. This is what I want for every woman watching this video. The evidence on HRT and breast density is genuinely more nuanced than a mammogram letter can convey. And density is a characteristic, not a diagnosis. And HRT-induced density is not the same as naturally occurring density. And most importantly, the type of HRT you are on matters. And your decision, whatever it is, should be made with the full picture. You deserve that conversation, and make sure you get it. If this video helped you, the most useful thing you can do right now is share it with a friend who is on HRT and has just had a mammogram, or with someone who has been putting off having this conversation with their doctor. I've put a link in the description below to the 5 questions to ask your doctor about HRT and breast density. You can download that and take it to your next appointment. And if you're a GP or a specialist watching this, or if you want to share something with your doctor that goes deeper into the evidence, here is a link to a video and a presentation I gave recently specifically for GPs that is on HRT and breast cancer risk. It covers data in more detail, including the different HRT formulations and what the studies actually show.